The question I get most often before the paperwork, before the intake, sometimes in the first message someone sends me is this. Is it autism? Is it ADHD or social anxiety or OCD? Could it be all of them? These are some of the most honest questions someone can ask. And it's also one of the hardest to answer well. What I want to do today is walk you through how a clinician actually thinks through that differential. Not a checklist, not a quiz, the actual clinical reasoning behind how we tell these conditions apart and what happens when they overlap, which they often do. Hello, I'm Dr. RB. I'm a licensed psychologist in the state of Florida and New York, as well as PsyPact, and I've been doing evaluations for over 20 years in my private practice, including evaluations for autism. Because what I see online, and I want to say this with real respect for everyone who is in the middle of this process, is that the conversation about autism on social media often misses the complexity. It reduces a genuinely intricate clinical picture to a list of traits. You check 7 boxes and something clicks. There's recognition, maybe there's relief, maybe there's grief. That recognition is real. So I'm not dismissing it. Self-knowledge really matters. But a checklist is not a diagnosis, and this is important. More importantly, a checklist cannot tell you which of these conditions is actually present, in what combination, and what means for how you get support. That's what today is about. So let's start with what actually distinguishes each of these 4 conditions, because they do have distinct clinical signatures, even though they share a lot of surface features. Autism spectrum disorder is at the very core about 2 things. The first is differences in social communication and social cognition. Not shyness, not introversion, a fundamentally different way of processing social information at a neurological level. A second cluster is what we call restricted repetitive behaviors and sensory differences. Patterns, preferences, routines, and sensory responses are consistent across environments and present across a lifetime. That second cluster matters a lot. When people think about autism, they often focus on the social piece, but the repetitive behaviors and the sensory sensitivities are equally central to the diagnosis. And they're often what distinguishes autism from other conditions that also affect social functioning. Social anxiety disorder is one of those conditions, and it's worth understanding exactly why it overlaps with autism, because the overlap is real and the distinction is clinically important. Social anxiety disorders is fundamentally fear-based. A person with social anxiety wants to connect with other people. They understand social norms well enough to know what's expected. What they fear is negative evaluation. They anticipate judgment, rejection, humiliation. Their avoidance of social situations is driven by that fear. And critically, social anxiety responds well to treatment. Cognitive behavioral therapy, exposure based approaches, sometimes medication, these move the needle because they work on the fear response. But autism is different. The social differences in autism are not primarily about fear of negative evaluation. They're about a different architecture of how social information gets processed. An autistic person may not pick up on certain social cues, not because they're afraid of missing them, but because the neurological system that processes those cues works differently. This discomfort in social situations is not fear-based in the same way. So, this matters clinically because the treatment is different. Exposure therapy designed for social anxiety works on the fear response. It will not change the underlying social processing differences of autism. And when a clinician treats autistic social differences as if they were purely social anxiety, they're applying the wrong tool. But here's where the complication comes in. And this is where the research gets very important to understand. A 2025 systematic review published in PubMed Central examining anxiety and autistic traits in adults found that approximately 84% of autistic people have some form of anxiety disorder. 84%. That means that most autistic adults, anxiety is part of the picture as well. In other words, they coexist. So when someone comes to me presenting with both autistic features and social anxiety, that is not evidence against an autism diagnosis. That is what the research would predict. So, what this means for you, if you're in this process, is that having anxiety does not rule out autism. Having social anxiety does not mean your social differences are only anxiety. A real evaluation has to look at both separately and then together. So, now let's go into ADHD, attention deficit hyperactivity disorder. ADHD and autism overlap more than almost any other pairing in neurodevelopmental conditions. A 2026 review published in Psychiatric Annals found that roughly 45% of adults with attention deficit hyperactivity disorder show significant autistic traits. Nearly half. And yet, a separate analysis of nearly 2 million US insurance claims found that only 1.7% of adults with ADHD diagnosis had a documented co occurring autism diagnosis. There is a gap between 45% and 1.7%, don't you think? The gap represents a lot of people, adults who have been diagnosed with ADHD and who may also have autism that has never been identified. So, why does this happen? Several reasons. First, the surface presentation really overlaps. Both conditions affect executive functioning, attention regulation, task switching, organization, time management. At a surface level, they can look very similar. Second, the attention dysregulation in autism can look like ADHD, especially in attentiveness, in adults who's developed compensatory strategies. Third, and this is crucial, autism is often camouflaged. Now, camouflaging is the set of learned social masking strategies that many autistic adults develop over a lifetime, especially women, especially people from marginalized communities who often didn't receive any recognition of autism in childhood. They have spent years watching how people interact, and they've learned to approximate social expectations well enough to pass. They make eye contact because they've learned to do it, not because it feels natural. They follow conversational scripts they've memorized. They perform social ease that they don't actually feel. A 2025 paper in expert review of neurotherapeutics specifically noted that diagnosing autism in adults is particularly challenging due to camouflaging and adaptive behaviors. Definitely challenging. When someone walks into a clinician's office presenting as socially comfortable, a clinician who doesn't know how to look past the surface presentation will miss what's underneath. That is why a developmental history is not optional. Autism is presented from early development. The question is not whether it emerged in adulthood. It didn't. The question is whether it was recognized. And for many adults, it simply wasn't. Now let's talk about the last leg, OCD, obsessive compulsive disorder. And this is characterized by obsessions, which are unwanted, intrusive, distressing thoughts, and compulsions, which are behaviors the person performs to get rid of those thoughts or to reduce the anxiety these obsessions create. The key word is intrusive. The obsessions feel like they don't belong to the person, like they're coming from outside. They feel like something happening to the person, not an expression of who they are. The compulsions are driven by anxiety. They're not pleasurable. They are experienced as exhausting and ego-dystonic, which is a clinical term that means they feel alien to the person's sense of self. Again, something that's coming outside of who they know themselves to be. So autism also involves repetitive behaviors. But in autism, repetitive behaviors typically serve a different function. They often feel like a natural part of the person. So that is the big difference. With repetitive behaviors in autism, it's part of who they are. They may be regulating, comforting, and it's sometimes even pleasurable. A specific interest pursued intensely is not an obsession in the OCD sense. It's a preferred activity, a specific routine maintained because predictability is regulating is not a compulsion. It's a coping strategy. So it's very different to cope and feel good about it or to try to do something to get rid of something. The clinical question is this: is the behavior driven by an unwanted, intrusive thought that creates anxiety, or is it a preferred self regulating pattern that the person chooses? That's the big difference. And again, co-occurrence is the rule here, not the exception. The same 2025 JCPP Advances study found that autistic individuals show significantly elevated rates of anxiety and OCD spectrum symptoms compared to neurotypical adults or adults that simply don't have any type of neurodivergent diagnosis. So having autism and OCD is entirely possible. It happens frequently. The key is that they must meet criteria for both individually. Even though, again, with autism, you have overlaps that may not meet the full criteria. For example, a person that has an overlap of OCD does not meet full criteria for OCD, but has OCD traits overlapping, something like that. Here is something I wanted to name directly because I think it really matters here. The way these conversations happen on social media often frames the question as binary. Am I autistic, or do I have ADHD, or is it social anxiety or OCD? The implication is that you can only have one. But in the real clinical work, the question is almost always which of these is present, in what combination, and how they interact. Many adults that I evaluate carry multiple diagnoses. That's not a sign that the diagnostic process has failed. That's a sign that human neurology is complex and that the categories in our diagnostic system are approximation. They're not containers or little boxes that you put people in. What that means practically is that even if you receive a diagnosis of ADHD or social anxiety, that diagnosis doesn't foreclose an autism evaluation. If something still doesn't fit, if the support you're getting isn't working in the way it should, if you still feel like the map doesn't match the territory, you are allowed to ask for a more comprehensive evaluation. So let me tell you what a real adult autism evaluation actually looks like, because I think there's a lot of confusion about this. So, a thorough adult autism evaluation includes a comprehensive developmental and psychiatric history. It asks about your childhood. What were you like as a kid? How did you get along with other children? Did you have a particular interest that you pursued intensely? How did you handle transitions and changes in your routine as a child? Were there sensory sensitivities? These are not incidental questions. Autism, again, is a developmental condition, and the features are usually present from early in life, even if they were never identified. So, usually around the ages of 4, 5, 6 is when you'll see it, and then even going into later childhood, because there are times where there's not an opportunity for those traits to show themselves. So when there are opportunities and the traits do show themselves, are they identified? A thorough evaluation uses standardized instruments designed specifically to assess autistic features, not a general mental health screener. Tools specifically calibrated to the features of autism in adults, which present differently than autism in children. A thorough evaluation takes camouflaging seriously. It doesn't take a polished social presentation at face value. It asks what the internal experience is, not just what the external behavior looks like. And a thorough evaluation considers co occurring conditions, not as alternatives to autism, but as part of the complete clinical picture. So if you have gone through an evaluation that felt rushed, that didn't ask about your childhood, that relied primarily on symptom checklists, that didn't consider the possibility of more than one thing going on, you are definitely allowed to ask for more. You're allowed to seek a second evaluation. This is your neurology. It deserves a complete accounting. So here is what I want you to take from this today. Your self recognition is not nothing. If something inside of you is saying, this might be part of my story, I take that seriously. Self knowledge is data. It's imperfect, but it's not worthless. And besides imperfect, I would also add it's incomplete. And you also deserve a real evaluation, not a quiz, not a 30-minute session with someone who doesn't specialize in this work, a thorough, careful, clinically grounded assessment that can hold the complexity of what you're actually carrying and give you a clear, honest answer. The right diagnosis changes everything about how you understand yourself and how you access support. The accommodations that help autism are different from the accommodations that help ADHD alone. The therapy that helps social anxiety is different from the support that helps autistic people navigate a world that wasn't designed with their neurology in mind. The self understanding that comes from an accurate diagnosis gives you a different map for your own inner life. And you deserve to have that map, don't you think? I work with adults for evaluations across the country. You can find me at discoveringmyself.com. The link will be below. I want you to keep asking the honest questions. That is exactly where this process has to start. So remember, you're guided, you are loved, and your path is sacred. Until next time, take good care of your soul.